pump coronary artery bypass grafting. Introduction. Coronary artery bypass grafting reduces the risk of death in patients with extensive coronary artery disease. GAP is usually performed with the use of a coronary pulmonary bypass. With this approach, perioperative mortality is approximately 2% with an additional 5 to 9% of patients having myocardial infarction, stroke, or renal failure requiring dialysis. The technique of performing GAP on a beating heart was developed to decrease the risk of perioperative complications and to improve long-term outcomes. Some complications, both perioperative and long-term, may be related to the use of cardiopulmonary bypass and to cross-clamping of the aorta in association with the unpumped GAP procedure.
This animation will show how a coronary artery bypass graft, or CABG, is used to treat coronary heart disease. Click the navigation arrows below the animation screen to play, pause, rewind, or fast forward the animation. The network of blood vessels that branch over the surface of the heart are called the coronary arteries. Coronary heart disease occurs when fatty deposits build up and form a plaque or atheroma on the artery wall. This causes the artery to narrow and harden, reducing blood flow to the heart. A CABG can bypass the blocked arteries so that blood can flow more easily. A coronary bypass graft, or CABG, is carried out under general anesthetic, which means that you'll be asleep during the procedure and feel no pain. If blood vessels from your leg or arm are being used for grafts, your surgeon will remove and prepare these first. A blood vessel, such as a superficial vein in the leg, which lies just below the surface of the skin, can be removed to use as a graft. A cut is then made down the middle of the breastbone or sternum, and the rib cage is opened so the surgeon can reach the heart. The surgeon may attach the new grafts while the heart is still beating, but it's more common for medication to be used to temporarily stop the heart. The blood is then rerouted to a heart-lung bypass machine. This takes over from the heart and lungs, it adds oxygen to the blood and maintains circulation. The graft is attached from your aorta, your main artery, to a point in the coronary artery beyond the blockage. Sometimes a graft is also created from the internal mammary artery, which is diverted from behind the sternum or chest bone. After the graft is attached, the heart is restarted with controlled electrical shocks and the sternum is rejoined using wires. The skin on the chest is closed with dissolvable stitches. This is the end of the animation. Click on the animation screen to watch it again.
Methods, application in medicine. Trial design. Coronary was a randomized controlled trial with the blinded adjudication of outcomes, in which off-pump gap and on-pump gap were compared in patients who were undergoing isolated gap. The primary hypothesis was that off-pump gap will be associated with fewer major clinical events in the short term than on-pump gap and that the benefit of off-pump gap will be maintained in the long term. We have previously published the trial design and the result at 30 years and at 1 year. Patients. Patients who were scheduled to undergo GAP were liable to participate in the trial if they required isolated GAP with median sternotomy, provided written informed consent, and had one or more of the following risk factors. At age of 70 years or more, peripheral artery disease, cerebrovascular disease, or carotid stenosis of 70% or more of the luminal diameter, or renal insufficiency. Patients 60 to 69 years of age were liable if they had at least one of the following risk factors: diabetes requiring treatment with an oral hypoglycemic agent or insulin, the need for urgent revascularization after acute coronary syndrome, a left ventricular ejection fraction or less than 35%, or a history of smoking within 1 year before randomization. Qualification of surgeons. To ensure that the surgeons were skilled in the technique assigned, we used the approach of an expertise-based randomized controlled trial. Each procedure was performed by a surgeon who had expertise in the specific type of surgery that the patient was assigned to undergo. Expertise was defined as more than 2 years of experience after receiving training and completion of more than 100 cases of the specific technique. Surgeons who meet these criteria for each type of procedure separately were considered to have expertise in both techniques and were allowed to perform both types of CAP during the trial. Trainees were not allowed to be the primary surgeon. Follow-up and trial outcomes. Study personnel conducted in-person or telephone follow-up with patients under their next of kin at 30 years and 1 year after a procedure and on a yearly basis until the end of the trial. If a patient indicated that any outcome event had occurred, the patient's physician was contacted to obtain source document regarding the event. The first co-primary outcome was a composite of death, non-fatal stroke, non-fatal myocardial infarction, or non-fatal new renal failure requiring dialysis at 30 days after randomization. In addition to being used to report results at 30 days, 12 this outcome was also assessed at 1 year. The second co-primary outcome was a composite of death, non-fatal stroke, non-fatal myocardial infarction, non-fatal new renal failure requiring dialysis, or repeat coronary revascularization at the end of the trial. We now report the results for the second co-primary outcome. All deaths in the first 30 days were considered to be cardiovascular deaths. All reported components of the first and second co-primary outcomes, as well as recurrent angina, were reviewed by an adjudication committee, the members of which were unaware of the treatment assignments. The outcomes as adjudication by this committee were used in statistical analysis. Quality of life was assessed with the use of the European Quality of Life 5-dimension questionnaire at the UQ5D visual analog scale. The UQ5D assesses 5 dimensions of quality of life. The total score range from 0 to 1, with higher score indicating very quality of life status. The UK5D visual analog scale assesses the response self-rated health on a vertical visual analog scale. The total score range from 0 to 100%, with higher score indicating better health status. In addition to the quality of life assessment, neurocognitive tests were performed before the CAP procedure at discharge, 30 days, and 1 year. The details of the test and their results have been described previously. The quality of life and neurocognitive tests were optional for both the patient and the investigators at the study sites. Neurocognitive testing was not performed at the 5-year follow-up, and therefore an assessment of neurocognitive status is not included in this report. Economic analysis. At the end of the trial, we conduct an economic analysis to evaluate the secondary outcome, the cost associated with each type of gap. We hypothesize if the trial protocol that the use of off-pump gap will be either cost neutral or cost saving as compared with on-pump gap. We report the results at 1 year. We have followed the same approach in this report for the results and at the end of the trial, with the exception that costs have been adjusted for inflation and we apply an annual discount of 3% because the trial spent many years of years and in US currency for statistics. Statistic analysis. All analyses were conducted according to the intention to treat principle. We use a time to event analysis with a cost regression to report the long-term outcomes after testing the assumption of proportional hazards. The time to the first occurrence of any one of the components of the primary outcome was described with the use of Kaplan-Meier survival curve, and the comparison between the two treatment groups were performed in a log-rank test. The treatment effect is expressed as the hazard ratio with 95% confidence intervals, which was derived from the Cox proportional hazards model for the second complementary outcome as 5 years. The comparison between the two operative techniques was assessed in pre-specific subgroup defined by diabetes status, cerebrovascular disease status, left ventricular function, number of licit vessels, sex, age, body mass index, region, and European system for cardiac operative risk evaluation grade. And tests for interaction were performed with the use of a Cox proportional hazards model. We also undertook landmark analysis to assess these outcomes between 1 year and 5 years, excluding data from patients who had the outcome evaluated in the first year and who had not followed data past 1 year. To analyze the quality of life data each follow-up point, we calculate the change in assessment score from baseline to the follow-up point for each patient, limiting the analysis to patients for whom data were available both at baseline and at the follow-up point being analyzed. The mean value for the change in score was then calculated within each group, and these means were compared between the two groups.
The development of newer cardiac stents has reignited the debate. Should patients with multivessel coronary artery disease undergo PCI or CABG? To answer this question, the BEST trial compared PCI using second-generation everolimus-eluting stents with CABG in 880 patients from 27 sites in Asia. Eligible patients had angiographically confirmed multivessel CAD and were considered to be suitable candidates for either PCI or CABG. Patients with clinically significant left main disease were excluded. At a median follow-up of 4.6 years, there was a significant between-group difference in the primary endpoint of death, MI, or target vessel revascularization, which occurred in 15.3% of the PCI group versus 10.6% of the CABG group. There was no significant difference in death or stroke between groups, but spontaneous MIs and repeat revascularization were significantly more likely to occur with PCI. The full trial results are available at nejm.org.
Results. Patients. From November 206 through October 211, a total of patients were enrolled at 79 hospitals in 19 countries on 4 continents and were currently assigned to undergo either off-pump gap or on-pump gap. The baseline characteristics of the patient have been reported previously. Second complementary outcome. At a mean of 4.8 years after randomization, a second complementary outcome event had occurred in 538 patients in the off-pump group and in 516 patients in the on-pump group. There were not significant between group difference in the rate of individual component of this composite outcome, including the rate of repeat revascularization, which was performed in 66 patients in the off-pump group and 55 patients in the on-pump group. In each treatment group, the rate of PCE performed because of graft failure was similar to that of PCE performed because of new lesions. Secondary outcome. During the overall period of the trial, there was no significance between group difference in the secondary outcome, mean cost per patient. There was no significant difference between the two groups at any point during the trial or in any of the category of cost. The group difference in physical cost was also not significant. Quality of life outcomes. A total of 2,000 845 patients initially agreed to provide data for the substudy of quality of life. There was a small decline in quality of life, as measured with the UQ5D and the UQ5D visual analog scale, in both groups at the time of discharge. But it was followed by a sharp increase in quality of life as perceived by patients in both groups at 30 days, and this higher quality of life was sustained to the end of the trial. There was no significant difference between the two groups in quality of life scores at any time point. Very similar results were found for the 1,531 patients who provide data at all follow-up points. Non-prescriptive outcomes. The rate of repeat coronary angiography was similar in the two groups. In the majority of cases, angiography was performed because of ischemic symptoms or suspected myocardial infarction. The rate of recurrent angina was also similar in the two groups, as was the rate of the primary outcome among patients who underwent the assignment procedure. In the landmark analysis of the data between 1 year and 4.8 years, the rate of the primary outcome was found to be similar in the two groups. Landmark analyses also show that the rates of repeat revascularization were similar in the two groups. As were the rates of repeated coronary angiographic and recurrent angina. Subgroup analysis. To test the consistency and validity of our results, we examined the treatment effects in various subgroups. No significant interactions were seen between the CAP procedure and any of the subgroup variables, with the exception of diabetes status. Hazard ratios for the second primary outcome in perspective. At 4.8 years after randomization among patients with diabetes, the second primary outcome had occurred in 250 patients. In the unpumped group, among the patients who did not have diabetes, the second primary outcome occurred in 298 patients in the unpumped group.
My name is John Eric Medich. I'm 59 years old. I'll be 60 this year. And I'm an American. I live in Alaska. And my diagnosis was I was having chest pains, and I diagnosed that I had clogged arteries on my heart by some kind of a reading system. The reason I picked the XL Hospital, which was GCN rated, the reason I picked the XL Hospital, I didn't really pick the XL Hospital. What I picked was Dr. Jose Hernandez. I read up on him and found out he started this hospital down here. And his credentials were impeccable. He's an American doctor. He just goes across the border and does his work over here, where of course it's not as expensive as our American hospitals. That's why I picked the XL Hospital. And it was pretty convenient too, it's just not even a mile across the border, so just like being in the US. Yeah, the doctors and the nurses, and they even have special people here to assist you. They all speak English. I mean, not all speak English. Take that back. But the ones that they have, like Pauline, asking me the questions. And they have Jessica. They have people here 24 hours a day that speak English, that can take care of all any questions or comments. major concerns, which is great. And the nurses here are really, they really care about the patients. Like the one nurse, Alex, she says, yeah, the reason I do this is I do it with love. That's how she does it. So I think that's good. Yes, I would recommend this hospital to anybody that doesn't have it. I don't know if the insurance companies cover going out of country. If one of my friends was in the same circumstances as me and a hospital that wasn't in the United States, I definitely recommend this hospital. If I need further surgery or any other things that I need, I'm going to come back to that same hospital. Well, I've been in the hospital the whole time. My wife's been here with me. She's been walking around shopping and going to different stores and things. And she doesn't seem to have any concerns at all about the security around our hospital. It's a really nice area. And there's shopping, restaurants. And there's a Starbucks right across the street. She goes over there and gets me coffee once in a while. It's a pretty good area.
Pros and cons of coronary artery bypass grafting. On the pro side of bypass surgery, the obvious advantage of this surgery is that normal blood flow is restored to the heart and the rest of the body. The patient's quality of life will be improved. Most people make a full recovery find their health greatly restored. Doctors usually recommend this surgery after other less invasive options have been tried. On the downside of bypass surgery, there are risks that must be considered. Traditionally, the chest is opened up to expose the heart, and then the graft is performed. Coronary artery bypass graft surgery is major surgery and as such carries a risk of bleeding, infection at the surgical site, fever, pain, anesthesia reaction, heart attack, stroke, and death. Not having the surgery certainly results in a diminished quality and length of life. Newer non-traditional approach uses small cuts in the chest wall to graft the bypass. Overall, new techniques like robotic surgery have given us the benefit of bypass surgery while minimizing the risk. It should apply in Ecuador. There are not specific data or number of how many cases are here in Ecuador for coronary artery bypass grafting, but it is estimated that about 3 or 4 people per year operate for heart disease. Conclusion. Although the results of CAP usually are excellent, there can always be complications. The surgery improves or completely relieves angina symptoms in most patients. Although symptoms can recur, many people remain symptom free for as long as 10 to 15 years. CAP also may lower your risk of having a heart attack and help you live longer.
A coronary artery bypass graft, or CABG, is performed to improve circulation to the heart muscle in people with severe coronary artery disease. In this procedure, a healthy artery or vein from another part of the body is connected or grafted to the blocked coronary artery. The grafted artery or vein bypasses the blocked portion of the coronary artery, carrying oxygen-rich blood to the heart muscle. One or more coronary arteries may be bypassed during a single operation. Your surgeon begins by making an incision in the skin over your breastbone or sternum. He or she will then cut the sternum and move your rib cage in order to get to your heart. Throughout the procedure, your circulatory system will be connected to a cardiopulmonary bypass pump or heart-lung machine. This machine temporarily performs the functions of your heart and lungs during the surgery, allowing your heart to be stopped while the surgeon sews the grafts into place. One of two blood vessels is typically used for the grafts: the internal thoracic artery in the chest or the saphenous vein in the leg. For the internal thoracic artery graft, your surgeon will leave the upper end attached to the subclavian artery and divert the lower end from your chest wall to your coronary artery, just beyond the blockage. Your surgeon will then sew the graft into place. For the saphenous vein graft, your surgeon will suture one end to the aorta and the other end to the narrowed artery just beyond the blockage. With the graft securely in place, your surgeon will use electrical signals to restore the heartbeat and attach a temporary pacemaker to the heart. Once your heart is again beating normally, the heart-lung machine will be disconnected. Your surgeon will wire the breastbone back together and suture the skin incision closed. A temporary drainage tube will be placed through the skin beneath the incision.